Good morning. My name is Cheryl Smith. I'm the manager for Patient Safety and Medical Home. It's 7 o'clock, so we'll get started. We have a filled agenda for this morning, but thank you for joining us. I know it's very early in the morning. There we go. So on the agenda, we have the community health workers from the PPOC regional support team here in each region. They will be sharing a lot of their success stories that they have had with referrals that you have sent over to the regional support team. And then from the Department of Children's and Families, we have Jessica Coolidge and her team. There will be DCF social workers in each region, and they will provide a presentation on communication between the medical home and DCF, and then their care services that are available as well. And then you'll have an opportunity to network with them at the end of the meeting. And we have no financial relationships or anything to disclose with the content within today's meeting. And then just as a reminder, we have microphones throughout the rooms in all locations, and we are recording the meeting. So if you could just keep conversations to a minimum so they don't come through on the audio. And then if you have a name tag, if you could just return it at the end of the presentation. So at the end of this meeting, you'll be able to discuss the care management services available through the regional support team, and then you'll be able to discuss communication between the medical homes and DCF, as well as the care services available through DCF. There's 2 nursing contact hours designated for this presentation for nursing. In order to receive those CEUs, you need to sign in and then also complete the post survey, and then those certificates will be emailed to you. These are the members of the PPOC Medical Home Support Program, and then the practice consultants by region. Of course. Who's logging in? We're going to pause for 1 moment. Babson is having difficulty logging in.
1 minute, we're just having some audio issues.
No problem. Sorry about that.
No, that was like last time when I tripped over the cord right after we tested.
I know.
Hi, Nicole, it's Cheryl. Can you hear me okay? She can hear? Okay, perfect. Sorry about the trouble. I'm just going to go back because Babson didn't hear any of this, so I'll just go back quickly here. So again, thank you for joining us for our longitudinal meeting this morning. In the objectives, we have the community health workers from the PPOC regional support team here, so you can meet them and they will just share some of their success stories from the referrals that you've sent to them. And we also have Jessica Coolidge and her team from DCF who will give a presentation on communication methods between the medical home and DCF and then the care services available through DCF. We have nothing to disclose with the content that we're providing today. And there's microphones throughout the room, so if you could just keep conversations to a minimum because this meeting is being recorded. And if you have a name tag, you can return that at the end of the meeting. Through the objectives, today you'll be able to discuss the care management services provided through the PPOC Regional Support Team and the communication and care services available through DCF. There's 2 nursing contact hours available for this program. In order to receive those CEUs, you must sign up, complete the post survey, and then that certificate will be emailed to you. These are members of the PPOC Medical Home Team and the practice consultants by region. And we have 4 MHCCs to welcome today: Paulina from Pediatric House Call, Franklin from South Suburban Pediatrics, Dorothy from Rosendale Pediatrics, and Marissa from Pediatric Care Associates. Welcome. And if you need any assistance, you can always reach out to one of the members of the PPOC Medical Home Team, your practice consultant, and here is a list of the medical home care coordinators on the advisory board. And we have a new member to welcome to the advisory board, who is Adair Medina from Holyoke Pediatrics. And then just a reminder, the PPOC has a new website. MHCCs do have access to that with the member page. If you have any questions about logging in, you can reach out to your practice consultant. Let's get rid of that. And then just as a reminder also, in the open peds, there's a discussion board. So if you have any questions that you would like to pose to your fellow MHCCs, you can post a question here. Or if you have resources or anything you'd like to share with MHCCs, you can post this here as well. And then this was something that we had learned about. I don't know if you're aware of it or not, that Tufts offers discounts and benefits for its members relating to well child visits that are completed. They will provide $25 grocery gift cards to children, movie theater tickets to teenagers, and Fitbits for 18 and plus who complete their well visits. There's also gift cards for immunizations that are completed, a gift card to receive a child booster seat or car seat, and also reimbursement $30 back if they participate with a gym membership, dance classes, sports leagues. In your packet, there's a flyer, and we'll put information about this as well up on Open Peds. If there's also a gift card for a completed asthma action plan, so any patient referred to the regional support team within the asthma team, the community health workers will help the families complete those applications. It's a form that has to get filled out and sent back to Tufts. And so I'd like to introduce the regional support team community health workers. If in each region, if you could come up to the front of the room, and we'll start with the story sharing with the South, we'll go over to the West region, and then into Babson for the North region. But I'd like to introduce, starting with the South. So within the regional support team, there's 2 levels of referrals. Level 1 is with Ileana, and I'll have you come over here. Just careful of that cord. And so anytime that you have questions, need some guidance, or you would like her to connect with a family to provide telephonic support and aligned services, Ileana is our central person. And then at level 2, that is telephonic support and home visits with our community health workers who will come up and share their stories. So here is Ileana's success story. Yeah, you can move that if you have to. I feel like
yeah, perfect. Awesome. So good morning. I've spoken with most of you or some of you, so I'm happy to be here. And so my story has to do with a 17-year-old young lady who has some medical complexities. She has in some medical complexities. She's wheelchair bound. She's turning 18. So by the end of this year, and dad has custody. That is a single dad with custody of the child. I mean, he's remarried, but dad has his child, and we needed to find her a neuropsych evaluation prior to guardianship. So the practice sent this family to me because they had not been able to locate a provider that could do the evaluation. It has to be, because of the guardianship, it's a legal matter. It had to do with a legal provider, a provider that can testify in court if he was to be called into court to testify in this matter. So I was able to locate a provider within 2 weeks. I found the provider, scheduled an appointment. With all this happened within a 2-week time frame. When I had to go to the evaluation with with dad, because that is a Spanish-speaking father, and he needed someone who could, help him through the process. So I went and did also facilitated the Spanish interpretation because the interpreter was going to cost an extra $250. That did have to pay out of pocket, and I'm a certified medical interpreter. So I ended up going to the family. So we ended up getting it all done. I have the report. All the providers that the social worker needed to sign it, I took the doctor sent me the report because I didn't feel comfortable being mailed to him, and because of the time crunch. So I got the report in the mail sent to me. I FedExed it over to I drove it to the social worker in Boston City Hospital. Children's Hospital Boston. She ended up then, once she did it, she FedExed it to the primary care provider, and we had the report back. And now it's in the hands of the medical legal partnership team, who is going to be helping the family in applying for the correct document and making sure that we go through the guardianship correctly. So that was, we put a lot of effort into that, and it's been successful. So the daughter's going to be turning 18, and that is happy that we are able to help them. Thank you.
Thank you very much. And then with Regional Support Level 2, this is the South team. Sydney is the clinical lead, and then the community health workers are Celia, Anna, Grace, and Jason, and they're here to present their stories. Celia, careful the light.
Hello, good morning. This is a 10-year-old male who resides in the home with his mother and stepfather and visits with his biological father on a daily basis. He came to us with a number of issues. One was he needed neuropsych testing. And I guess there was a question as to where it could be done, who would do it, who would pay. So we did locate someone. He was tested at the end of May, diagnoses autism. So meanwhile, one of the other problems that we were having was his ISP, the IEP. The mother wanted to appeal it. We did contact the appeals office in Boston. After explaining what was going on, he suggested mediation instead, should be the first step. So I met with the mother and a number of the school officials. They were very gracious, actually. They were more than willing to not just meet with us, of course, but adjust the IEP for the new coming year to include some time throughout the week for this young boy to spend some time in what they call a sensory room. And also, he had been obtaining some in-home services that included therapy, but because he had so-called graduated, they had actually closed him out in December of last year. So that came back into place. I worked with the behaviorist and, of course, the pediatric office on that because they needed a referral from the pediatrician. But everything is in place. He now sees a therapist, I believe it's every other week. So we're doing well there. And also a caveat to this is that the mother herself, her entire academic career, she was in special education. Up until the 11th grade when she had to drop out. So she functions at a pretty high level, but when it comes to very lengthy intakes or applications, she gets overwhelmed. So one of the several home visits that I had with her, I actually had to sit down with her and actually help her fill out this application. She knew how to complete the basic contact information, but when it came to questions where she had to explain certain things and give reasons, that's where she had a hard time. So she wasn't working at the time, but since then, everything is in place for the child. We do have a follow-up IEP meeting in October for the child. And like it reads, mom is back to work. And she herself is getting therapy as well. So far, so good. Let's see what happens in October.
Great job, Celia. And then this is Grace.
Hello. So I am working with a family who was referred to us because the it's a new patient to the practice, and mom had filled out the health needs assessment form, but didn't hand the form in until after leaving the well check. So the PCP was a little concerned about some of the questions that mom had responded to, and just wanted me to give mom a call just to kind of make sure everything was okay. So during the phone call, I identified some of the immediate needs that needed to be looked at. So mom had said that she didn't really have any food left for the weekend. So I was able to help her find a place that was open that also worked with her work schedule. And she also said that she does not have transportation. She's been spending a lot of money on Ubers every day to go to work, to and from. She lives fairly far away from where she works. She's spending about $50 for Uber. We were going over food stamps and information on DTA. So this is still ongoing, but we had found out that she had applied for food stamps and was denied twice. But when we were going over why she was denied on the app, we found that she was probably applying with some information that wasn't correct. So we're gonna go to DTA together. I had prepared a checklist on some documents for things that she'll need to bring in that will help her qualify for cash assistance and food stamps. And so right now she's working on gathering those documents, and then we're going to meet at DTA together and hopefully get her some benefits.
And then Jason.
So my case was, that's supposed to be an 11-month-old Cheryl. That should be 11-month-old. It's okay.
Oh.
My case was an 11-month-old female who had been in for a well visit and had checked off housing, transportation, and food on the health needs assessment. So I received the referral and then met with mom a couple days later. She informed me that she had housing basically up till the end of the summer. She was living in her ex-husband's parents' house, but the house was sold and was closing at the end of the summer. And she had been involved in the housing process since she left rehab and got custody of the kid back a few months prior. She also told me that the father of the baby and her had a major domestic violence past. And then Ileana actually gave me a resource for an agency called Dove, which is an agency that provides a bunch of resources for victims of domestic violence. And we actually got her moved up the housing list with a letter from them. We got her food stamps by just helping her fill out the paperwork. And then she'd been missing a number of appointments for the patient. And working with the MHCC, we were able to get her transportation, and she has made all of her well visits and checkups since. And she actually just got housing a couple of weeks ago, which is very quick since we just started working with her about 2 months ago. And that was pretty straightforward.
Thank you, Jason. And then we have Anna.
Good morning, everyone. So this is a 12-year-old male. This family is, they were a victim from Hurricane Maria in Puerto Rico not too long ago. So they've been in this country only for like about a year and a half. So the reason for the referral was that mom needed some help with the child's asthma. But once we were in the home, we were able to identify a few other issues that they were having at home. So they have an unsafe home environment due to presence of mold in bathroom and in urgent need of an air conditioner. As you all know, this summer, there was a few days that was really, really hot. And this family had no AC at all. So even when we were at the home visit, it was really difficult to be there because it was really hot. So that was like my number one thing that I wanted to help this family. Besides his asthma and other conditions that he had. So we were able to help this family to get a low-cost air conditioner to put in the child's bedroom. As you may see, this patient also has other conditions like anxiety, depression, and panic attacks due to what they lived, what they went through in Puerto Rico. So, you know, this was the extreme heat was causing him to have more panic attacks during the night. So that's why I made that my number one goal, to get an air conditioner for the family. So we were able to find a low-cost air conditioner, and also through the help of a community church, we were able to find another air conditioner. So now the family has 2 air conditioners. I also provided the family with asthma education. We provided them with a steamer to help clean off the mold in the bathroom. The mold wasn't a big issue, but mom was a little concerned about it, but she was able to fix it using the steamer from the program. We also provided them with other supplies like the vacuum cleaner, the air purifier. Mom was also having some difficulties paying off their electrical bill. So we also connected mom with the PACE office, and they were able to help her to set up a payment plan for this. Mom texted me a few days ago, and she says she's really happy with the help she received from the regional support team, and she's extremely grateful for having her 2 air conditioners, and now she's in a better place.
Thank you. Thank you. And now we'll transition over to the Western region for them to share their stories. Dan Barrio is the program director of the regional support team. Jane O'Brien is the complex care manager. And then Jasmine and Damaris are both community health workers. And Dan, if you could unmute on your end, Dan, and then we have Jane to share her success story.
Jane's on her way up to the podium.
Perfect, thank you. Share while Jane's coming up to the podium. Anytime that you have a question, need, concern, you just might need some help with something, always call into the regional support team. We will never tell you no, we cannot help you. Even if it's not something that we can do within the regional support team, we'll identify another resource to help you. We'll never leave you stranded and say, no, we can't help you. So just always call in with any questions if you need help with anything.
Okay, this is a 4-year-old who's medically complex. There's a long list of issues. He's blind, he has diabetes insipidus, growth hormone deficiency, seizure disorder, Chiari malformation, developmental delay, he's blind, he's fed by a G-tube, and they had no services. And mom did any kind of fired EI when he was 2, so she would have gotten the help to get him into school with them. They're having some issues with food insecurity, utilities. They had no services at all, except for DDS. And when I called DDS, the guy told me that she never called back. And that's the way it was with me at first, but now we've developed a wonderful relationship. And I provided her with 4 food resources, utility resources. I made a referral to Bridging Care to Families, and they're working with her. I made a referral for a PCA, and mom is just thrilled because she's wonderful. And I've been encouraging her to sign him up for school. And I referred them to Make-A-Wish, and they're going to Disney on Friday. And mom does call me back, and it's nice because at first she was a little hesitant, but now we have a nice relationship. And he's getting the services that he needs. Anything else?
Maris, we have your case next.
Okay, I am not Damaris. Damaris is on vacation this week, but this is too good a story not to tell. So one of the practices referred to 18-year-old male who had type 1 diabetes and ADHD. He had had 2 hospital admissions in the last 7 months for diabetic ketoacidosis and had missed 2 years, had been 2 years since he'd seen his PCP, and it had been a year and a half since he'd seen his endocrinologist, and he missed a post-discharge follow-up appointment with the endocrinologist as well. The practice had tried to reach out to the person, and there was just no answer to any phone calls. They or any other efforts to reach him. They reached out to the regional support team in Damaris, physically went to the home and knocked on the door and found the young man and had conversation with him and got appointments made to re-engage him with his PCP and his endocrinologist. He was able to get, he had not taken insulin in some time. He had gotten, they had been tipped off that he was out of insulin by his eye doctor who called the practice. So they were able to, when they got in there, they did a health needs assessment and learned that he had housing issues, food issues, no job, no transportation, no phone, so no way to be contacted. They were able to work with the VNA who came in and did teaching, and the community health worker attended the teaching so that she could do follow-up reinforcement with the patient. They were able to get him a phone through Tufts. They were able to connect him with a food bank who provided him with some groceries and some gift cards. And we were also able to help him get a job so he could earn some money and have access to food. And now he has regular support from the CHW and has seen his PCP as he's supposed to, has seen his endocrinologist, hasn't been back to the hospital since we've been engaged with him. And things are looking up for this young man. So she did a really great job with this case.
And then we have Jasmine.
Oh. She might be muted. Hold on. Jasmine is stuck in traffic and she's doing this remotely. Okay, well, I'll help Jasmine because she's stuck in traffic and she probably, maybe she dropped the call. So Jasmine's patient is a 4-year-old patient with asthma. They were referred because of their asthma exacerbations to our asthma home visit program. When they got into the home, they found out that they had lots of issues on their health needs assessment, that they wanted to move because there was all sorts of activity in the apartment building that was concerning to the family. The mom was heating the apartment with her gas stove because the heat was controlled by the landlord and it wasn't warm enough. Someone was shot right outside their front door. The children were very upset by this. They wanted a therapist for the daughter because she had witnessed the shooting. Mom didn't understand about administering the asthma medications properly, and they were missing lots of school every week because of the asthma. So with Jasmine's help, they were able to get relocated to a new apartment. In her new apartment, mom has control of her heat. So they were able to get out of that old apartment so that where all the illegal activity was, so they were able to get out of there and resolve that issue. They now have a home therapist for the daughter. The mom's got improved self-management of the asthma due to the asthma home visit program, and they've not been missing school or work since our engagement. So mom feels far less stressed out about her whole situation. The family feels safe in their home. They feel a lot better about how they handle their child's asthma, and the child is feeling much better about where they live now, and they're playful, energetic, and happy. So another great case. Sherry,
North.
there you go.
We have our North Regional Support Team over at Babson, and so they'll continue the presentation over there. You'll be able to meet the community health workers and hear their success stories.
Okay, try again.
From the beginning? From the beginning. Okay. So, hello. My name is Lynn Sullivan. I'm the program manager for the North Regional Support Team, and I have with me today our community health worker team from the North Regional area, Tamar Jerome, Jennifer Sagastumi, and seated is Scarly Severino, who's on day 3 of employment with children, so we're not going to pressure her to come up, but she can wave and say hello, and we're happy to have her on our team. I wanted to share with my team a couple of our stories from our short time. As you know, our team has been going for the shortest amount of time. We've really just kicked off within the past month or so, but we have a couple very exciting stories to share with you. If I can make this work. Okay. So Tamar's story is first. Do you want to share?
Sure.
Okay.
So this patient is a 10-year-old little girl. She was referred to our program for asthma and also overweight. So I went into the home, did asthma education, technique reinforcement, and all of that. And then upon arriving, I had them fill out a health needs assessment form and found out that they have other issues, social determinant issues that I needed to address. The first one is food. They had insufficient funds left for food. The caretaker is a grandmother who is the legal guardian of the granddaughter. The mother and father is not present in her life. So she right now is on SSI and is not receiving enough income to support herself and her granddaughter. So she basically had insufficient funds left for food. So what I did is I connected them with food pantries in their local area, actually brought groceries to the home where the grandmother was just very excited and so overwhelmed that she was in tears. Also food market programs, our farmers market programs where they're able to use their SNAPs food stamp benefits to basically get money in return for purchasing groceries, for purchasing fruits and vegetables. Also housing, she was worried about housing security. Currently they're on Section 8, and so she was just worried that she wouldn't find a new placement. So she right now is on the waiting list for Reading Community Apartments. Transportation, she wasn't able to make it to her appointments because her car broke down and she didn't have enough funds to repair the car. So I connected her with senior bus discounts where she was able to go in and purchase a senior bus pass. MBTA, also a PT1, so that way she can make it to her appointments. So she's a very overwhelmed grandmother who has a lot of burdens and a lot on her plate. So we found a grandparent support group where, in her local area where she's able to go in and, connect with other grandparents who are raising their grandchildren, get advice and just support from them. Understanding of health, so, again, asthma education reinforcement. The child wasn't taking the control as directed, so there's lots of reinforcement on that, and now the granddaughter is taking her controller meds twice daily, and she hasn't had any ED visits recently, which prior to my visits, she had multiple ED visits. Also, she's currently in summer camp, Boys and Girls Club. She loves it. Again, she's overweight, so she's been very active and exercising, and she just is having a great time this summer in summer camp, so she hasn't missed any days there. So that is all.
Okay. So the next story is Jennifer's. We're going to present together. I'll have her pipe in if she has anything to add. So I'm just going to turn the screen so I don't have to keep turning my head. So we're talking about a little guy who's a 3-month-old former 27-week preemie who was discharged from a MGH facility at North Shore Children's. So they were in our ACO, but they had MGH providers. The baby had a lot of complexity from his preterm birth, including hearing loss. He didn't really have asthma. He had chronic respiratory disease. He had some issues with his gallbladder. He had neonatal anemia. He had an abnormal newborn screen. He was readmitted with pneumonia within days of coming home from the hospital. He was referred to us through Tufts. They reached out to say, who's going to handle the discharge education with this mother for this baby, you or us? So our answer to that was, well, we're going to use your resources for that because that complex education is a little bit more than we're prepared to do any one of our areas. But we want to work alongside you with this because this baby is going to have ongoing constant needs for the next little bit of time, and we wanted to have our community health workers involved with the practice as part of the team to be able to support the mother, to learn the education alongside of her, and then be able to reinforce it if needed. It turned out that that education was the least of the problems for this family, as expected, I guess, right? So mom, it turns out, has developmental delay herself. She was in denial of that, and I'm sure it was apparent during her hospitalization with the baby, but it didn't come as a notification to us. Additionally, she had, as I said, MGH providers, and as we know, at the end of the year, they aren't going to be a part of our ACO any longer, so we had to make a decision whether we transition this baby's care to Children's now or Children's later, because unless she changed PCPs, that was what had to happen. So Jennifer had a long talk with mom about that. Mom was very worried that all the specialists already knew her baby that she would see, and how could she change to a specialist that had never seen him before? So she had, mom made contact with a couple of these specialists, and they told her that indeed they really didn't know her baby yet. They would meet the baby. So that helped ease the transition, be able to switch her care over to Children's. Mom did not want to give up her PCP, nor did she want to give up Jennifer by this point. They're kind of attached at the hip at the moment. That would probably be an understatement. So upon spending more time with mom, we were going to meet her at a visit, and we went there for her visit, and mom didn't come. And now we're worried, like, where's mom with this little preemie who's not showing up for her visit? Well, she showed up about an hour and a half later. She had transportation issues. An opportunity for Jennifer to get some time in the waiting room with her, and then to have a conversation after her appointment, where mom revealed to us that she lives with her own mother, with extended family members. Many of, at least one, but some smoke. Housing isn't stable. They were going to be evicted the following week. There was an eviction court case a week later. She also had unstable income that was coming to the mom was being taken by the grandmother. And also the grandmother had put all the utilities in the mother's name, and she hadn't been paying them. So that was just one of her problems. So mom had no car, was unable to get to appointments. She was relying on a cousin who was handicapped to transport her places, which is why she was late to the appointment to begin with. She only has her cousin as a support. The father of the baby wasn't really in it for the long term, and he lived in a separate city away from mom, miles and miles away. And mom did not understand the complexity of caring for a preemie when they come home, or a child when they come home, nor did she understand her own health issues, her own developmental delay, which was affecting her ability to function. So with all of this, you're not going to hear me mention Tufts once, because the continuing care nursing, with visiting nursing, came to the home. Mom was doing great with taking care of the baby. Like, that wasn't a problem. Mom also had an issue because the baby required a specialty formula. Baby had neck as a neonate and had about 10 centimeters of her colon removed. So they had a bit of short gut, and they had a compounded formula that was processed at a separate pharmacy and had to get to mom, but had to always be under refrigeration. And there was some complexity with getting it to her where she was, or her getting it without transportation. So Jennifer worked some miracles with this mom. She was able to establish a connection with her, help her make sure the baby had and maintained insurance. Once she never provided the Social Security card to Mass Health, so the insurance got dropped somewhere along the way. So that was all taken care of. She was able to connect her with benefits that she was entitled to, including SNAP and WIC, gave her information about food pantries. Mom was getting some cash benefit. She stayed with the cousin for a while because of the smoking in the home and some unstable relationships there. And then we were able to get her to emergency shelter, where they were not in a community with a lot of snotty-nosed kids. We wanted to kind of keep them clean so that the baby didn't get sick again while he was so, I guess, delicate would be the word, a little, recently discharged. We were able to get a payment plan for his utilities while they set up some ongoing plan for that. Grandma's eviction hearing did not result in her being removed from the home, so grandma was still in the home. And transportation was arranged for a myriad of appointments, along with transitioning all of the appointments to children's using their liaison. And if you've dealt with any preemies that go home, there is a long list of providers they need to see in a short amount of time. And the sooner you get them into a NICU graduate program where they have a team taking care of them, the better their outcome will be. So we're able to arrange that. It hasn't been without its speed bumps. Let's just say there's been many emergency calls, some of them at 6 a.m. saying, my ride isn't here. Mom left the shelter because during the heat wave, she had no air conditioning and it was sweltering in there, and she felt she needed to have air conditioning. The baby wasn't sleeping. We were able to get her a pass away for a weekend to get her a respite, but then she chose to leave the shelter. So once she did that, as you know, they come off the housing list. So she's back living in the home with the grandma right now, and we're hoping to get her reconnected with a plan for her own stable housing. We were able to make sure that the mother now understands the type of care that baby's going to need and why, and that she'll obtain it. Mom also acknowledged that she has her own learning disability, and through some documentation with her physician, that's going to actually help her be able to take advantage of appropriate benefit to help them get the care they need. She needs ongoing help and support in order to have some success with this baby. Mom is very on the edge still. An example of that was most recently when we had a small snafu with her transportation to a recent specialist appointment. We were able to get her there in plenty of time, and she dropped her phone getting out of the car, and it shattered. And it put her over the edge. She was in tears and hysterical, and then she couldn't walk in the hospital. So she got all the way there to the front door and didn't make the appointment. And then we lost touch with her. We couldn't get in touch with her for 3 days. So Jennifer went looking for her Tuesday, knocked on the door and gave it some thought about where she would possibly go. She was really upset or something didn't go well, and went to the cousin's house, knocked on the door, and sure enough, Mom was there, and she told the tale of what happened, and she was just too overwhelmed to take another step into that hospital door and face those specialists, so she didn't make those appointments. Knowing that information, we were able to call liaison, speak with the physician offices, and help to hopefully Mom rescheduled her appointment. So Jennifer's working alongside Mom, helping her do what she needs to do and not doing it for her, and trying to teach her what she's going to need to do to be a successful mom of this baby that's going to require a lifetime of events. And that's about it. She did a spectacular job.
So I just want to give a couple of quick updates. So the first is in regards to Epic. So as you all know, we are upgrading Epic this evening, I believe. One of the changes that you'll notice is that there are some new options for reason for call. We have 3 new options there. The information about these is outlined in the Cadence Prelude user guide that you can look at. But this is to help when you're doing your transitions of care phone calls so that you can accurately document the type of call that you're doing, and then you're able to run reports more efficiently. If you have any questions about that, please ask your practice consultant. So a quick update. So through mid-June, from the beginning of the year to mid-June, 31% of our PPOC patients have had a health needs assessment completed, which is really great. So thanks to all of you that are doing that work in your practice. We continue to see that kind of our top buckets of needs are regarding utilities, as well as extra supports that are needed. And again, if you have any needs that you feel like you can't address in the medical home, please call our regional support team. So I'm going to hand off now to our guest speaker from the Department of Children and Families. So we just wanted to share a little bit of data. So right now in our BCH ACO, we have a little over 1,400 members that have some sort of affiliation with DCF, and I'm sure everybody can think of at least one patient in their practice that this applies to. And so we are really glad that we have Jessica Coolidge here with us today, who's going to kind of give us an overview of some information. For those folks that are on the line, if you could please chat in your questions and chat them to everyone, not just the host, and then we will read them to Jessica. And if anyone in the room has questions, we're going to hold questions until the end of the session. Okay.
Great. Thank you so much for having me here today. So as Nicole pointed out, I'm Jessica Coolidge. I am the statewide medical social work specialist with DCF. We're very fortunate to have a very comprehensive health and medical services team at DCF now, which I'm going to talk briefly to you about today. We do have a few people in our audience today as well who are part of my team. We don't have anyone here at Babson with me, but if those of you in Bridgewater want to say hello to Alicia Davila and Paula Henry. Alicia is with the New Bedford DCF area office, and Paula Henry is with the Brockton area office. And then in the Northampton setting today, we have Kristen Hoyt, who drove in from the Springfield DCF office to join all of you. Okay, and just a quick overview before we jump into Mass Health enrollment for foster care youth. I just wanted you to take a quick look at your packet. There's a couple of handouts, they're contact sheets, and these are for you and your practices, so please hold on to these. You'll see my contact on the front page here, part of the Health and Medical Services team. Feel free to email me if you have any questions after this session today. But our Health and Medical Services team is based of, we are very fortunate to have a medical director, Dr. Linda Sager, who was a pediatrician for years at UMass Medical in Worcester and started the FACES Clinic, which is the foster care clinic that still exists at UMass Medical, along with the child psychiatrist, Wynn Morgan, who is also a child psychiatrist at UMass Medical, the supervisor of nurses, Mary Lutz, who is a nurse, myself, who's a social worker, and then we have 5 DCF regional nurses who sit in each of our 5 DCF regions, as well as, do any of you know Lynn Sullivan Galvin, who is a nurse at Children's Hospital in Boston, formerly a diabetic nurse? She is our, we're so very fortunate to have her. We had Deb Sorrentino previously, prior to her retirement, but she is our nurse liaison and works closely with Boston Children's Hospital as well as our DCF team. And what all of us do on this front page is we don't provide direct care to DCF youth, but we provide consultation statewide. We provide consultation to DCF staff. We provide consultation to outside providers as far as bridging that gap between DCF youth and really the medical world. And then we're very fortunate, if you take a look at the second contact sheet, you'll see a contact sheet that looks slightly different. We were very fortunate that a little over 3 years ago, we were able to hire the first of its kind nationwide, a care coordination team within a child welfare organization. And that actually resulted in 29 medical social work positions statewide. So we have 29 area offices, which is why there are 29 care coordinators. These care coordinators are all masters of social work, MSWs, who either hold an LICSW or an LCSW and provide care coordination directly correlated to kids in foster care. A lot of that involves care coordination around navigating pharmacy barriers, barriers related to accessing health care, much of which is related to our very complex Medicaid system here in Massachusetts. A lot of you may have met them. Many of them go out to provider practices within their catchment area to also help bridge that gap and build relationships between DCF and local providers. Have any of you had an opportunity to work with them in the past? You have. And they also assist with ensuring that kids coming into foster care have access to medical screenings and comprehensive exams. And I'm happy to announce, since they started 3 years ago, we have about a 90% compliance rate statewide of all kids coming into foster care getting access to healthcare screens and comprehensive exams, and before it was below 20%. So it's a huge increase. So the last remaining 10% are usually outliers. We have a large adolescent population that might be on the run and aren't accessing health care, kids who are in inpatient behavioral health settings, or kids who may go home within a short period of time and don't have access to a health care screen that is set up with us through a provider office because they've already returned home. So we wanted to talk briefly today about Mass Health enrollment for foster care youth. So patients receiving Mass Health via DCF are exempt from open enrollment periods. That means that we as the Guardian can actually change their health insurance plan at any time. They can also pick and choose any plan, but they are exempt from having to choose a plan. So that means that they can still remain on this thing known as fee-for-service, also known as Mass Health Standard. How many are you familiar with that? I know that there had been very limited information when Mass Health was doing the ACO rollout to providers that would still exist. I know that they've done an exceptional job with working with us and provider communities since that time to really educate providers around the fact that we are still one of only 2 remaining populations which can remain on fee-for-service, also known as Mass Health Standard. That being said, most of our population, kids coming into care, are on an existing PCP plan, MCO, or ACO. We attempt to try to keep them with their existing health insurance plan. Continuity of care, right? We try to keep them with their existing providers. So if they come in with an existing plan, we try to keep them with that current plan that they are on through their family's Medicaid coverage. Now, this includes, all of these things includes children who are not just in foster care, but children who are adopted through the Department of Children and Families or have a DCF-sponsored guardianship. We have many families, many children who are adopted through our agency who receive a subsidy through our agency. That includes a financial stipend as well as Medicaid, which is Mass Health. They too are exempt from open enrollment periods and are also able to stay on fee-for-service, also known as Mass Health Standard. So this still occasionally comes up statewide with practices where families are being asked by providers to enroll in their contracted ACO or MCO. That should not be happening. If there are questions regarding that from your provider practice, please outreach to me. We are very fortunate to have fantastic contacts at Mass Health who have individually reached out time and time again to provider practices to help explain this. It often seems there's just sometimes at some practices there's a breakdown in communication, but those youth do not have to choose an ACO or an MCO. And if you're contracted, which you all are, with a Tufts ACO, your practice therefore is contracted with Mass Health and can indeed accept fee-for-service, aka Mass Health Standard. Any questions regarding that? Next slide. So due to the complex needs of youth in foster care, we really are strongly discouraging foster parents or providers. We've had some providers who do web enrollments on our kids or other patients as well. We're discouraging people from doing that. We have a team of care coordinators at our office, like I just discussed, who are available in the office 99% of the time. They do not carry a caseload. They sit in area offices. They are much more available than DCF social workers who are managing caseloads of 18 to 22 cases and are often on the road. Our care coordinators are very skilled in navigating the Mass Health system. If there's a concern related to the insurance, that it's an insurance maybe that your practice doesn't accept or a new patient to you, please go ahead and reach out directly to that care coordinator, again, on that list of 29 contacts that you have that I passed around. If they're not available, you can email me directly. I provide coverage to all of those offices when any of those medical social workers are out on vacation, sick leave, or maternity leave. You can reach me, and at that point, we'll go ahead and evaluate and decide whether or not it makes sense to change the insurance so they can be seen at the practice, and go ahead and make that change on our own. If it's appropriate to make that insurance change, we can make that change within a couple of hours. We have contacts at Mass Health that do that for us, and we will go ahead and do that so that they can still be seen. If they have an appointment at your practice that day, they can still get in for that scheduled appointment. So let's really just quickly talk about why we don't want foster parents or providers doing web enrollments on our kids without first having discussion with the care coordinator, the medical social worker in the DCF area office. I'm going to give an example. So Heather, the name has been made up, but this is a very true case. We have cases like this quite often. Heather, an 8-year-old girl, came into foster care with a BMC Health Net plan through Mass Health. Due to her being placed in a foster home at a geographic area, she had to switch to a new primary care physician. This often happens, although we try for it not to happen. The foster parent had selected that primary care physician. and her new primary care physician did not accept BMC HealthNet, at which time the foster parent called Mass Health and enrolled her in a Boston Children's Health ACO that the provider accepted. Makes sense, right? She had an upcoming appointment. She couldn't be seen unless she was on that BCH ACO. Nobody checked in with the DCF office before making this change. The child who had scheduled infusions and a meeting with her ongoing therapist of 2 years that day was turned away from both appointments due to the change in insurance. Why did that happen? Let's talk about this. Well, now she's able to see her new primary care physician, but she wasn't able to get her infusions because what do infusions require? Prior authorization, like a lot of procedures, like a lot of medications as well. Those prior authorizations have been approved through her previous insurance plan of BMC HealthNet. That's since been changed. She now needs newly approved PAs through her new BCH ACO. Nobody thought of that prior to making her change in insurance. We have now, as an agency and guardian, now prevented this child from accessing care. The therapist who's been has had a standing relationship with her for 2 years only accepts the behavioral health plan of Beacon Health Strategies, which is through the BMC HealthNet plans. Child is now on a BCH ACO, those are Tufts plans, and all behavioral health goes through Tufts. Her therapist does not accept that behavioral health coverage. So we have now prevented her from having access to 2 different providers. This is often what is not thought about by foster parents and sometimes provider offices. We see this on the behavioral health end as well. Behavioral health providers will say, well, I only accept MBHP. And so we end up having to change that plan to a plan that it carries the MBHP coverage, not thinking about how that will impact access to the existing providers that the child is already seeing. So it's a very complex system, and this is one of the reasons, just one of the great reasons why we're so lucky to have care coordinators in DCF offices, because we have thousands of kids coming into foster care with one of 18 different health insurance plans, at least, because we do have kids come into care with TPL, which is third-party liability commercial insurance plans as well. So this actually occasionally comes up as well. This is actually a provider notice that you can find on the Mass Health webpage. It's a provider bulletin, so you don't have to worry about recalling this today. If you want to print it out, you can go directly to the Mass Health provider bulletin page. But the Federal Healthcare Financing Administration has informed the Division of HCFA's position that Medicaid providers are not permitted to bill Medicaid recipients who miss scheduled appointments. So that means if you have a patient in your practice who has missed an appointment and they're on Medicaid, Mass Health, we should not be billing them for missed appointments. Again, if this is a little unclear, you can actually print out this bulletin from the Mass Health page. It's actually a little outdated, but they don't have, it's from 1999, but it's the most recent provider bulletin they have regarding it, and it's still relevant. If for practices are still confused about that and want further clarification, please feel free to email me, and I'll have somebody directly from Mass Health reach out to your provider practice. So this comes up often, and I know that there were some questions today that Nicole and Anna had wanted me to answer specific to what's the difference between what can a foster parent consent to and who is a foster parent versus who is DCF when a child comes into foster care, and what does DCF consent to. So it's really a languaging. I like to describe foster parents, and this is sort of throughout our policy of who are they? They are considered a substitute caretaker. So when a child comes into care, into DCF custody, care and custody, DCF becomes the guardian. The foster parent is a substitute caretaker. So if you thought about it with your own children and you were leaving them with a grandparent for a weekend while you traveled, or a babysitter, the babysitter or grandparent would be a substitute caretaker, not the guardian in those situations. It's the same thing here. A foster parent is a substitute caretaker, caretaking for the child while they're not in their home setting. So it's our policy that the substitute caretaker, so foster parents, that also includes group care providers, at the request of our agency, will assume responsibility and the provision of routine health care services. So what does that look like? This means that they can arrange for emergency treatment when necessary. They can schedule routine appointments and follow-up appointments. They can provide non-specialized care. They can arrange for and coordinate the provision of specialized care as required. And they can and should inform us, we're the guardian, of any changes in the child's health status. And that includes changes in any new updates regarding medications. And we also expect that they transport children to and from medical appointments. However, we know that often our agency, the DCF social worker, does that, but it is an expectation that the foster parents, as the substitute caretaker when available, do that. So as stated, they're substitute caretakers. They can consent to routine care, and that includes immunizations as well as well-child visits. Us as the guardian must consent to hospital discharges. So sometimes there's a source of confusion around this even with our agency. When we have a child that is inpatient or we have taken custody of a child while they have been inpatient, DCF becomes the guardian. We sign the discharge paperwork. The substitute caretaker, however, needs to be the individual who's at the hospital doing the training because they're going to be caretaking for the child. So they should be there on the day that the child is discharged. They should have gone in ahead of time to do the education that is needed. If you have a child who is being seen in one of your outpatient practices and they have special health care needs, we need to make sure that that foster parent is getting the training they need. I stress this to DCF social workers all the time. If they are taking kids to medical appointments, they should not be educating the substitute caretaker on medical treatment, how to utilize a nebulizer, what signs to look for when a child's having an asthma reaction. We need to make sure that that substitute caretaker, since they're caretaking for the child, is the person hearing that information firsthand. So for instance, if a substitute caretaker cannot make a medical visit and there's some instructions around the care of the child, how do we make sure that substitute caretaker is getting that firsthand information? Do they need to place a follow-up call into the provider practice to speak to a nurse? Do they need to schedule a follow-up visit to come in and get that education? Same thing, on the day of a surgery, it is DCF as the guardian who consents to anesthesia. Quite often the substitute caretaker will be the one who's present on the day of surgery, but it is DCF who needs to consent. So normally they'll get the anesthesiologist will get consent ahead of time, but the morning of will need consent, and so the DCF area office will set it up if it's before office hours, that there's somebody who can be available via cell phone, maybe a manager, or even our DCF hotline may be aware that a call might be coming in so that DCF can go ahead and consent to that anesthesiology for that surgical procedure that morning. But foster parents should not be consenting to anesthesia. So what information can be shared by provider practices when a child is in DCF custody? So there's 3 different custody types, and we're not going to go into them extensively today, but we do obtain custody of children voluntarily. So parents voluntarily place kids in our custody at times. We also do obtain custody of children via what is known as a child requiring assistance, CRA, also formerly known as a CHINS. And mostly we obtain custody of children via a care and protection petition known as a C&P, and that's when there's protective concerns for a child remaining in their home. Regardless of custody type, the DCF office, our office should be contacted. If you are aware that a child is in DCF custody, they show up with a foster parent, they show up with a group care provider, you can outreach to our office to get either a letter stating that they're in custody on letterhead, or you can get a legal minimus, and I'm going to show you an example shortly. We'll also provide you information at that time if asked around what custody type that child is in, and if the office is having confusion around what should be released and what should not be released, we'll walk you through it at that time. Sometimes we have compliance officers from medical practices reach out to us as well to have a conversation around that. This actually often comes up around what do we release regarding adolescent patients. The information that should be released to DCF regarding adolescent patients would be exactly what your practice is related to what would you release on adolescent patients to a parent if the child was living at home. And our team has sort of looked high and low for really clear statutes, legal regulations on what is the age here in Massachusetts. And maybe you guys are better at answering this, but we have not been able to find anything here in Massachusetts. And so you could ask one provider what their practice is, and they would say, well, you know what, I usually check in with my 15-year-old patient about what they feel comfortable releasing, and then we release that to the parent. Or another practice might say, another provider might say, you know what, and all patients over the age of 16, I'm not releasing anything to the parent. So that is really a conversation to have with your practice around what are your policies and practice around releasing information on adolescents to a parent. Whatever that practice is, that would be the same for DCF. So we often are asking, we have a population of youth, and I'm sure some of you do in parts of the state as well, related to kids who are being commercially sexually exploited. We have adolescents on the run who often are picked up and then seen in an emergency room and treated for STIs. And they're going to a group home setting, and at the group home setting, medications are held by staff member. And so quite often a staff member at that group home setting, they're the substitute caretaker, will show up and they'll ask for information on that medication because they need to know all the medications that children are on in their group care setting. And, you know, EDs sometimes will give us that information and sometimes they won't, but those are the reasons why we're asking, because those group care providers are managing those medications and holding them. But again, it goes back to whatever the practice is of the facility or your provider practice around the release of information, confidential information on adolescents. That should be practiced the same way for if a youth was in DCF custody. We should be treated the same way as if a parent would. And that's it. Are there any questions? I know there's always usually a ton of questions about DCF. Any quick questions before I hand it back off to Nicole? Do we have to check from other locations?
Yeah, we're gonna give people a minute to chat and their questions.
Hi, I'm Leah on the program
Hi, Leah.
manager. Hi, everybody. Since DCF is here, I just wanted to quickly comment on the Special Kids Special Care program.
Yes.
Many of our practices have patients that are enrolled in this program. And this program, although our practices are exclusive with the Tough Boston Children ACO, when they implemented the new Medicaid models back in 2018, they did include a provision that allowed us to continue to see kids in the Special Kids Special Care.
Sure, I'm sorry.
You're fine. This isn't working.
No, it's not.
I'm sorry. You guys get to listen to it again. Hi, everybody. I just quickly wanted to mention the Special Kids Special Care Program, which is administered by BMC. So when the Massachusetts implemented the Medicaid models in 2018, in which we went exclusive with the THPP, Boston Children's ACO, they did include a provision which allowed providers to continue to offer care to these medically complex patients that are in DCF custody. It's a fairly small number because the complexity on these patients has to be pretty significant for them to be eligible. But if your practice does have a patient that's enrolled in the BMC Special Kids Special Care Program, you will hear from me. And so I will work with BMC to make sure that the necessary paperwork is filed so that your claims can then process. And so typically I'll reach out to your practice manager, your billing manager, or your credentialer, whoever in your office would take care of those type of things. I think we've gotten most of your practices, but if there are new patients enrolled that are yours, then you'll hear from me. And so if you see kids with BMC Special Kids Special Care Program, just know that it's okay to see them. And please don't turn them away for appointments. Reach out to me if you have any questions. And again, my name's Leah Baza. Many of you may know me, or your practice managers know how to reach me. And then the only other thing I wanted to mention is sometimes you don't know when you're running eligibility yet if a patient is enrolled in DCF or has some kind of DCF custody. If you look into the EVS system in Mass Health, when you see a patient has Mass Health Standard and you click on that, you'll see underneath that questions should be directed to the social worker, and that kind of clues you in right there that there's some type of DCF involvement. So I told Nicole I would give her a screenshot so she can share that after today's program, so that way you can see what that looks like. Okay, so I just wanted to share that. Thank you all for listening, and feel free to reach out with any questions.
Yes, so I'll talk really quickly about this. So we just want to remind everyone that if you have patients who are in foster care or technically in DCF custody, you should not be giving MyChart access to the foster parents. I know that sometimes, a lot of times you're giving the MyChart access when they're checking in at the front desk. It may not really be clear to people, but make sure you're flagging those patients somewhere in Epic and you're not giving them MyChart access. If right now you're thinking of a parent that may have it, please, feel free to contact us. We really want to make sure that we turn that access off. Yeah, go ahead.
What if there's an adoption in place? What if they're fostering and they're going to be adopted in 6 months by the same family?
Yeah, this is actually a really good thing too. So when a child is legally adopted, even though their name is changing for the most part, I would say 99% of the time that the legal name changes, they will get issued a brand new Mass Health ID with their new legal name, but it often doesn't happen until 2 or 3 months past the legalization date. So we were trying to get this information out to our adoption units as well, because what happens is our subsidy case doesn't pick up until post the legalization date. And so for provider practices, keep using that foster care pre-adoptive name until you actually are given a brand new Mass Health ID by the family.
What if they're going to have to switch them over to private insurance and just set the Mass Health as a secondary?
And that's different. Then they'll give you the private insurance information, but they're still going to get the Mass Health as a secondary, but that often is not going to pick up till 2 or 3 months. Yeah. And we actually are discouraging a lot of our families from picking up commercial insurance. They don't often understand that commercial insurance is fantastic, but a lot of the kids adopted through our agency have extensive behavioral health needs. And they're not realizing when they're putting them on the commercial insurance, how all of a sudden that becomes the primary insurance, really limiting their access to the secondary behavioral health coverage. So it's usually a conversation we'll have with the family, but we have had a lot of adoptive families who have called later on and say, what do you mean my Mass Health now isn't primary? That's a Medicaid rule, not a DCF rule, that Medicaid's the payer of last resort. So.
All right, Jessica, I'll let you go through just your next couple of slides, and then we do have some questions that have come in over the chat.
Oh, goodness, I forgot I had a couple more. That's why I handed it over to Leah and Nicole. Okay, so communicating with DCF, this can be challenging. I know DCF workers are extremely busy. I'm not making excuses, but I was a DCF worker many, many years ago, and it is an even more challenging job today than it was when I was in the field. So they are the case manager. They are responsible for speaking with collaterals, meeting with families, going to court. They are the ones case managing the case. So if there is a question, you really should direct it to the DCF case manager unless it's strictly insurance related. If it's strictly insurance related, you can go ahead and reach out to that medical social worker in the office. But if the DCF social worker is unavailable, which there's a high likelihood they are out in the field the majority of the time, you are more than welcome to contact their supervisor. You can contact the front desk at the office and you can ask to speak to their supervisor and leave a message for both. And again, if the questions are specifically related to insurance and access to care, such as a barrier related to insurance, maybe a medication issue, that can go ahead and be directly bounced to the medical social worker. And we talked briefly about this, but if your office needs documentation that a child is in DCF custody, you can request this from the area office. Absolutely. Now, you can request, the reason I say you can request a letter is because we don't always have a legal minimus. If we remove a child on a weekend, which happens often, sadly, but if kids come into care and custody over the weekend, we haven't gone to court yet. We're still covered under a legal statute that allows us to do an emergency removal and take emergency custody. However, we don't have a legal minimus because we can't go to court until the court is open the following week. Or if the child was removed today, this morning, I'm taking custody from the child at school this morning at 8:30. I'm not going to be able to file my affidavit until later this afternoon, and so I don't have anything, I don't have a legal MIT yet, but you can absolutely get something on letterhead stating the child was just just moved via an emergency. This, however, is what a legal minimus looks like. It's not blue, it's just the way I cut and pasted it. It's white, but it's just a one-page document, And it looks like this. It will include the child's address, the name, the date of birth, which court, and then a date here. And so this is actually the date in which the minimus is good until. So usually we have status dates in court every 3 months. So if this date is expired, you're going to want to go ahead and request a new legal minimus. But if you need something in writing, that should be in the chart. Again, it's a really easy one-page document. And if you need that urgently, again, if you can't reach out to a DCF social worker or supervisor, you can go ahead and reach out to our medical social workers. Sometimes their offices don't have these right on hand, and so it may take us 24 hours to track this down through our legal department. But we can, in the interim, send you something on letterhead. And that's it.
Great. So we have a couple of questions. If you can just repeat the question.
Sure.
Here. So can DCF notify practices when they have a child in custody?
That's a great question. Can DCF notify notify practices when they have custody of a child or a child comes into DCF custody? Yes. Do I think that happens as often as it should? No. The reason it doesn't is because workers are in the middle of a lot of things and they're removing a kid. They're removing a kid, they're obtaining medications, they're placing children. But we're very fortunate, like I mentioned earlier, to have care coordinators in our offices now who are medical social workers who quite often are red flagged immediately when a child comes into care. And quite often, the day of or the day after, are outreaching directly to your provider practice anyway to get an updated list of immunizations, to find out if there's any medical concerns. So that's actually been happening more consistently in the last 3 years. But the medical social workers would only know if a child came into DCF custody if they're being notified immediately on the day. If not, sometimes they don't find out until 3 or 4 days later after it shows up, and we have like a data report that gets run on a daily basis of kids coming into care. And then usually foster parents are the ones who are reaching out to your practices. This should be sort of a red flag to schedule what is known as a 7-day medical screening. How many of you are super familiar with that now? I mean, that policy has been around for 10 years, but we weren't in really good compliance with it up until we hired our care coordinators 3 years ago. And so all of you should be getting probably regular telephone calls from foster parents or group care providers saying we're trying to schedule this medical screening, or even follow-up calls from medical social workers from our office. So that should be happening. If that's not happening with your practice, I would love to get a quick email from your provider practice and connect you with that medical social worker who covers your catchment area.
Great. What if a provider prescribes an antibiotic for something like an ear infection? Do they have to notify DCF?
Okay, great question. So does a provider need to notify DCF if they are prescribing a foster care child an antibiotic? They don't, but as we mentioned, it is the role of the substitute caretaker. That's their responsibility to be notifying us. And then what we do, so they can go ahead and consent to routine medication, but we have a practice where we really want our social workers to be doing consultations on medication changes or new medications with our regional nurses. And this actually comes up more often with antipsychotic medications. We have lots of kids on very high doses of antipsychotic medication. We're looking very closely at that now. We're doing some special projects here in the next couple of years with Medicaid to take a closer look at that. And so particularly with antipsychotic medication or any psychotropic medications, I should say, we really want to make sure that it really is the responsibility of the substitute caretaker to be letting us know that a prescriber has prescribed an antibiotic, Adderall, a change in the Adderall. Even if the child's on cough medication, we want to, if we're the guardian, be notified, but that really is the responsibility of the substitute caretaker, not the provider.
Does every patient in DCF custody get the MHBP benefit?
They don't, and that's confusion. Even some of our staff think that, okay? So when kids come into, so years ago, almost 20 years ago when I started in the field, every child that came into foster care got straight Medicaid, fee-for-service, that came with MBHP. That changed a number of years ago, even, as you all know, even prior to the ACO rollout. There were 5 different MCOs, but it's still, you know what, it's hard to still get that message out, even though we're trying that. No, when kids come into care, we issue them mass help. But if they are on an existing MCO, ACO, PCP plan, they come into care with that plan. If that plan carries beacon health strategies or coverage through TUFS, that's the behavioral health coverage they get. But there is and some of you might have seen this in your roles and practices, we are working closely with Mass Health around the issue of unlinked IDs and kids having multiple Mass Health member IDs. I'm sure some of you have run into that. Which plan do I bill? Our care coordinators are checking insurance on every kid coming into foster care within the first week of coming into care. And I would say 9 out of 10 of those kids have unlinked Mass Health IDs. And so if they have an unlinked Mass Health ID or they've never had Mass Health before and we're issuing Mass Health for the first time, they do get Mass Health fee-for-service with MVHP.
If a DCF worker has documentation of PCP on file, do we still need to submit a release to request information from DCF about the patient or family?
So you might have to rephrase. So if a DCF patient has a listed PCP on file,
does the PCP still need to have someone sign a release?
Does the PCP still need to have someone sign a release to get the information? So I'm a little bit confused around, is it the PCP is looking to speak to somebody? So there should, if you have, again, legal documentation on file, a letter or a legal minimus, you can speak to DCF. If there's confusion by the provider practice around who they can speak to, go ahead and you know that that child is in DCF custody, go ahead and reach out directly to that DCF worker for clarification. I hope that cleared it up. If not, go ahead and retweet, resend us a message.
If we file a 51A and open a case but have ongoing concerns, do we need to submit another 51A?
Oh, I love this question. Okay, love this question. So, yeah, so if I have filed as a provider, a mandated reporter, a 51A, and it's been screened in, so they're supported, there's an ongoing case, there's a social worker working with the family, and I have ongoing concerns, do I need to refile? Do I need to resubmit another 51A? So, if it is the same concerns as the first 51A, I would say the first step would be to be speaking with the social worker if there's a signed release, because we may not have custody. We quite often are working with families and we don't have custody. Just because there's an open case doesn't mean we have custody. However, if those concerns are not getting better and you still have suspicion, that's all you have to have as a provider, suspicion of abuse or neglect, and or there's new concerns, I'm still going to say that you address it with a social worker, but you also file another 51A. So as a mandated reporter, you know what, if you have working with a family and concerns for physical abuse, and now there's a report of sexual abuse, you'd file another 51A. If there's concerns for physical abuse, but now there's another new concern for physical abuse, you're going to file a 51A. If you know what, even this happens a lot actually with schools, chronic head lice. How many of you have patients in your practice with just continuous head lice, right? You're addressing it with a social worker, but the family, for whatever reason, still isn't following through. That's an ongoing concern that you have for neglect. Now the kid can't go to school. It's not getting treated appropriately. You've addressed it with the ongoing worker. I would still say go ahead as a mandated reporter and file another 51A. The worst that's going to happen is we're going to get that report. At least you've had it documented that you filed another report, and we might screen it out.
Should the 7-day screening visit be billed as an office visit or a well visit?
That should be billed as an office visit. And you know what? So the provider practice asked, should the 7-day be billed as an office visit or a well visit? You know what, I'm going to say to that office, can you email me? And I'm going to connect with some other provider practices around how they bill that, because I'm not exactly sure from a billing perspective.
Should we distribute this to the whole group?
Yep. Yep, we'll include that in the follow-up email. Is the medical social worker or the caseworker calling the practices to check in about the patient's last visit, immunization, et cetera? So who's doing that, medical social worker or caseworker?
So that should be the caseworker. So the caseworker is responsible for assessing risk on an ongoing basis. So the only way that we can close cases is whether or not we're speaking to people who are involved in the case. So it really should be the case manager who's the caseworker. We call those collateral calls. They should be contacting providers. we encourage that, and we hope that that's happening frequently. If that is not happening and you have concerns, please feel free to reach out directly to the provider. The reason that you may consistently hear more also from the medical social worker is even though they're not case managing the case, they may be calling because the kid just came into care and they're trying to get some updated information from the provider practice before the child gets placed in foster care. But it should routinely be the case manager calling for updates because they're the ones working with the family and assessing risk. And part of assessing risk is finding out from people who are working with the family if they have concerns or not and what those concerns are.
Anyone in the room have questions? Feel free to raise your hand and just repeat them.
From my team, actually, if the community health workers are involved or becoming involved with a family, we get referred generally from a practice or from TUP, and we connect with the family and find out the child's under custody. Can we request that letter if the practice does not already have notification?
Yeah, so the question is, if community health workers are already working with a family, which you guys are doing fantastic work, by the way, I think that's a great way to also prevent families sometimes from getting involved with DCF and connected to more natural supports in the community. Can we request, and we find out that the family is connected to DCF, the child may be in DCF custody, can we outreach to DCF to get something in writing, something in letterhead or a minimus? You absolutely can. We often may not even know as an agency that you guys are involved with a family, so it's very helpful for us to work as a team. So if the family is, we may not have custody, that would be a question to ask the family. Hey, do you know if DCF has custody of your children, or are you just working with a DCF worker? And to get a signed release from the family if they're just working with a DCF social worker so that you can go ahead and outreach to us, because we may not know. And when I say us, the DCF social worker, caseworker who's working on the case, we may not be aware that you're working with the family, and we don't want to duplicate efforts either.
Any more questions from the room?
Great, thank you all.
All right, great. So we're just going to wrap up really quick, and then we're going to go into regional breakouts. So I just want to remind everybody about our webinar Wednesdays. Our next one is coming up in September. It'll be about increasing MyChart utilization. All of the recordings and the slide decks are available on Open Pediatrics. You can see how to get to them here, so please go through and review those. If you don't have access to Open Pediatrics yet, please contact us. Let us know, and we'll make sure we can get you set up. And as a reminder, anybody in the practice can have access to the MHCC Open Pediatrics page. It's not like on Blackboard where we had to limit the number of licenses. So if your practice manager or others in your practice want access, we'd be happy to give them that. If you are looking for nursing contact hours, make sure that you've signed in, and you also need to complete the SurveyMonkey that'll be sent out after the session, and then we'll send your certificates via email in a few weeks. Please make sure you fill out the SurveyMonkey even if you don't need credits. And our next meeting is December 18th. So we're going to shut off the Zoom now, and we're going to just stay in our regional groups.